Today I will talk about management of a critical care unit. This is part of my series of lectures on hospital functioning or hospital management. Various critical care units in a hospital include burn care unit, coronary care unit, surgical cardiothoracic care unit, medical or surgical care unit, also commonly known as intensive care unit, pediatric medical surgical care unit, known as pediatric ICU, neurological, that is neuro ICU, neurosurgical, that is neuro ICU surgical, and trauma ICU or TICU. First of all, I will talk about design requirements and then I will talk about key performance indicators for management of critical care unit. In design requirement, I'll talk about design team. I'll talk about location of critical care unit in a hospital. I will talk about sections of an intensive care unit. I'll talk about alarm systems, flooring, other details, and supplies. Design team should include an ICU medical director, ICU nurse manager, chief architect, hospital administrator, engineering staff. It is desirable to include other departmental heads, especially anesthesia, medicine, and surgery departments, and environmental engineers and interior designer. Location of ICU should be such that it is near to emergency laboratory and radiology services. Traffics in ICU is mainly from emergency room, OPD, operation theater, and wards. Another traffic is from the family members of the patient admitted in ICU, and there should be a reception in between. Patients after treatment in ICU are discharged, and there is separate supply traffic. So this supply traffic, the patient traffic, and the public traffic should be preferably be separate from each other. Sections of an ICU include patient area, nursing station, and others. Patient area should be in a units of 8 to 12 beds. It should be a modular design, and for a bed, there should be an area of 250 square feet with at least 15 feet width. Nursing station should be such that patient beds are in direct line of vision. Other sections of an ICU include positive and negative pressure isolation room. This depends on the epidemiology of the catchment population or community. Then there should be a special procedure room. There should be a medication area, which should be at least 50 square feet with a refrigerator. There should be a nourishment preparation area. There should be working equipment storage area. There should be clean and dirty utility room. There should be a storage space. There should be a clerical space. There should be an administrative area. There should be a conference room, and there should be a reception area, which act as a gatekeeper for visitors or family members of ICU admitted patients. Sound levels in a daytime should be less than 45, in the evening should be less than 40 decibels, and in the night less than 20 decibels. So alarm system like cardiac alarm, etc. of ICU patient should be below this decibel level, and alarm system should be audible or should be present at nursing station, staff lounge, ICU conference room, on-call room, and hospital telecommunication center. Flooring and ceiling should be such that it absorbs sound. Flooring should be easy to clean and should help in infection control. Flooring should be easy to maintain and flooring should permit easy equipment movement. There should be clean and dirty utility room without any communication between these two clean and dirty utility rooms. In a dirty utility room, there should be no air recirculation. It should be connected to an exhaust. So ventilation system should include UV germicidal irradiation system. There are of two types, duct irradiation by UV lamp or upper room irradiation by UV lamp. So there should be a heating, ventilation and air conditioning system in ICU. Supply should be as a utility column, and if it is not as utility column, the supplies can be mounted to the head wall or head side wall of the patient. Electric supply should be grounded. It should have an emergency backup and there should be a circuit breaker in case of emergency. And there should be at least 16 outlets per bed. Water supply should have a zone stop valve in case of emergency and disaster. There should be two outlets of oxygen supply per bed and one outlet of compressed air per bed. Compressed air pressure should not be more than 50 to 55 per square inch. There should be a vacuum connection with a vacuum of at least 290 millimeters of mercury. Now let us see what are the key performance indicators for management of an intensive care unit or coronary care unit or critical care unit. So the key performance indicators in my lecture, I have divided them as mortality indicators, morbidity indicators, operational or process indicators, error and patient safety indicators, infection control indicators, human resource indicators, overall employee satisfaction indicators, customer focus indicators, process indicators, capacity strain indicators. So this is the list of KPI which I will cover in this lecture. So let us see one by one each. The mortality indicator includes standardized mortality rate. As risk of death varies with severity of disease state, age and comorbid conditions, overall mortality is not a suitable indicator. We cannot compare overall mortality between two different ICUs in two different hospitals because of different in the composition of diseases. So we need to have a standardized mortality rate, which is defined as observed rate divided by risk adjusted expected rate. Risk adjusted expected rate is nothing but predicted death rate by a predictive model, and the benchmark should be 100. So if it is more than 100, it is a matter of concern. If it is less than 100, it means it is a good performance or better performance. Morbidity indicators include iatrogenic pneumothorax, incidence of acute renal failure in non-coronary intensive care unit, and pressure ulcers. Iatrogenic pneumothorax rate is defined as number of pneumothorax divided by number of cases multiplied by 1000. And the benchmark is 0.83 per 1000 cases. Our value should be less than 0.83 per 1000. Or if we combine interstitial emphysema, pneumothorax, pneumomediastinum, and subcutaneous emphysema, it can be up to 5%. Incidence of acute renal failure in non-coronary ICU is equal to number developed severe renal failure divided by number managed in ICU multiplied by 100. It should be less than 5.7 for severe acute renal failure, and it should be less than or equal to 10% of all types of acute renal failure. Pressure ulcers include stage 1, 2, 3, 4. Stage 1 indicates superficial color change of the skin. Stage 2 represent partial thickness skin loss. Stage 3 is full thickness skin loss. Stage 4 means deep and extensive tissue damage involving muscle, tendon, or bone. So pressure ulcer rate is equal to number of pressure ulcers divided by number of cases multiplied by 1000. It should be less than 3 to 11% or should be less than 22 per thousand or 2.27%. Now operational or process parameters. I'll talk about process indicators in later part of this lecture. So few of the operational indicators here include length of stay, compliance to protocol, and ICU readmission rate. Length of stay is total hours and days patient managed in the unit with midnight bed occupancy, which is more accurate than the number of calendar days the patient spent in the ICU. So length of stay is equal to total occupied bed days divided by number of patients in a given time frame. And the time frame can be weekly, monthly, yearly. So average length of stay in the year 2001 at Norfolk General Hospital was 4.36 days in general ICU and 2.43 days in vascular ICU. Compliance to protocol rate is equal to number of times a protocol is followed divided by number of times it is expected to follow, multiplied by 100, and it should be more than or equal to 90%. ICU readmission rate, readmission to ICU within 24 hours of transfer during a single hospital stay. This is an indicator of post-ICU care. So ICU readmission rate is equal to number of readmitted patients within 24 hours divided by total patients managed in ICU multiplied by 100. And it should be less than or equal to 5 to 6%. Error rate or patient safety indicators include patient fall rate, medication error, adverse events or error rate, needle stick injury rate, re-intubation rate. Error is defined as the failure of a planned action to be completed as intended or the use of a wrong plan to achieve an aim. So patient's fall rate is an untoward event which results in the patient coming to rest unintentionally on the ground or another low surface. So fall rate is equal to number of falls divided by number of ICU bed days multiplied by 1000. And the benchmark is 8.46 falls per 1000 bed days with an injury rate of 12.85%. Medication error rate is defined as number of errors divided by number of bed days multiplied by 1000. Medication errors range from 1.2 to 947 per 1000 patient days. Median is 105 per 1000 patient days in adult ICU, and it is 24.1 per 1000 patient days in neonatal ICU. Wrong dose, the benchmark is 106 errors per 1000 patient days in ICU. So adverse event or error rate is equal to number of errors divided by number of bed days multiplied by 1000. And the benchmark is all adverse event 80 per 1000, preventable adverse events 36 per 1000, serious error rate 149.7 or 150 per 1000. Needle stick injury rate is defined as incidence per 10,000 venipunctures, and the benchmark is 0.94 per 10,000 venipunctures in United States. Reintubation is defined as reintubation within 48 hours of extubation. It is equal to number of reintubations divided by number extubated multiplied by 100, and its benchmark is 12.2%. Infection control indicators include ventilator-associated pneumonia, bloodstream infection due to central line, urinary catheter-related infection. Ventilator-associated pneumonia is defined as by radiological signs, clinical signs. Radiological signs include more than two serial chest radiograph with at least one of the following, that is new or progressive and persistent infiltrate, consolidation, and cavitation. Clinical signs, at least one of the following should be present. Temperature more than 38 degrees centigrade with no other recognized cause. Leukopenia or leukocytosis. For elderly patients more than 70 years, altered mental status with no other recognized cause, and more than two of the following: new development of purulent sputum, change in character of sputum, increased respiratory secretions, or increased suctioning requirement, new onset or worsening cough or dyspnea or tachypnea, rales or bronchial breath sounds, worsening gas exchange, that is oxygen desaturation ratio less than 240, increased oxygen requirement or increased ventilation demand. So these were the criteria for diagnosis of ventilator-associated pneumonia. So it is defined as number of patients with ventilator-associated pneumonia divided by number of days mechanically ventilated with endotracheal tube multiplied by 1000. And the benchmark for 1000 device days is 5.3 per thousand for general surgical cases. Bloodstream infection due to central lines defined as number of central line associated bloodstream infection divided by number of central line days multiplied by 1000, and benchmark is 2.3 for general surgical cases. Urinary catheter related infection is defined as number of urinary tract infection divided by number of catheter days multiplied by 1000, and the benchmark is 4.1 for surgical cases. Human resource indicators include overall employee satisfaction. Overall employee satisfaction can be measured in a scale from 1 to 5, where 1 represents lowest satisfaction and 5 indicate highest possible satisfaction. And benchmark is it should be at least 4. The score should be at least 4. Customer focus indicators include patient centeredness, and patient satisfaction is a perceived parameter by the patient, and it is possible by those patients admitted in ICU who are capable of giving feedback. Then process indicators, there are two articles which I have considered for this lecture. In one article, the process indicators were Rickman Agitation Sedation Score, or RASS. It should be measured in a particular frequency. And these are the deviations mentioned in this article. This is the source of article. Then behavioral pain scale, mean arterial pressure, tidal volume, peak inspiratory pressure, and blood glucose. So these are the process indicators as described in this article. Then process indicators as described by this author in this article include: one is semi-recumbent position in patients undergoing invasive mechanical ventilation. The second indicator is monitoring sedation, analgesia, and delirium. Third indicator is lung protective ventilation. Fourth indicator is weaning protocol incorporating spontaneous breathing trials. Fifth indicator is early and adequate initiation of antibiotic therapy, that is within 1 hour after diagnosis. Sixth indicator is therapeutic hypothermia after cardiac arrest. Seventh indicator is early enteral nutrition. Eighth indicator is documentation of relative or next of kin communication. Ninth indicator is hand disinfection consumption. And tenth indicator is ICU administration by an attending intensivist and provision of a physical 24-hour ICU presence of at least on-board certified intensivist. Now, finally, let us see what are the indicators which indicate capacity strain. So, capacity strain indicators include ICU census like bed occupancy and bed availability, queuing, nurse to patient ratio, daily rounds by intensivist, ICU transfer, ICU acuity, after hours discharges, turnover, workload, early ICU discharge, refusal rate, ICU readmission, standardized mortality rate, burnt out, job satisfaction, and surgery cancellations, elective surgeries which are postponed or cancelled due to ICU bed unavailability. So this is all for today. Thank you very much.